Imagine a medical procedure that is so veiled in taboo that it's rarely discussed in public.
Yeah, almost never.
Right. But it boasts an over 95% patient satisfaction rate, and it relies on the exact same science as your favorite facial serum.
It really does, which is fascinating.
It is. So today, we're cutting through all that cultural secrecy to look at a really interesting landscape in intimate women's health. Welcome to the Deep Dive.
Thanks for having me.
We're taking a close look at the clinical realities of labial filler, which is, often whispered about as labia puffing.
Yeah, that's the colloquial term you hear a lot.
Exactly. And our mission for you today is to understand exactly how hyaluronic acid filler is safely assessed, how it's applied, and probably most importantly, how it actually settles in the labia majora.
And we have a really solid stack of sources for this today. It's purely empirical. We're pulling from randomized controlled clinical trials, updated medical guidelines, and some really comprehensive plastic surgery literature.
So no guesswork here.
Right, no guesswork at all. These sources detail the rigorous safety protocols, the biological mechanisms, and honestly just the anatomical complexities of the vulva that demand a highly specialized approach.
The secrecy around this, it really reminds me of the early days of facial Botox.
Oh, absolutely.
Like 20 years ago, nobody breathed the word about it, even though thousands of people were benefiting behind closed doors.
Nor is this a massive secret.
Right. So we're setting that same clinical, strictly educational tone for you today. And to establish our baseline, the literature makes it super clear that we aren't just talking about a cosmetic whim here.
No, definitely not.
Volume loss in the labia majora, the outer fleshy lips of the vulva, has profound functional implications.
Right, because as aging occurs, or following childbirth, or during really significant hormonal shifts like the estrogen drop you see in menopause, the tissue of the labia majora just loses its deep fat pad.
It just depletes.
Yeah, it loses that structural support. This hypertrophy or volume loss, it leads to very real physical consequences.
Because that cushion is gone.
Exactly. Without that protective cushion, patients experience chronic chafing against their clothing, persistent pain during activities like, cycling or intercourse, and just a severe reduction in localized tissue hydration.
Wow. So it's a functional barrier that's basically breaking down.
That's a great way to put it. Form and function are completely intertwined in this area.
And before we explore how doctors actually rebuild that barrier, the sources emphasize a really critical distinction that I think often trips people up.
Oh, the difference between the procedures.
Right. We have to separate labial filler from labiaplasty.
Yes, that is so important to understand.
Because if a patient comes in with significantly loose excess skin on the inner lips, the labia minora just pumping the outer lips with hyaluronic acid isn't going to solve the problem.
No, the mechanics of those two procedures are just entirely distinct. Labiaplasty is surgical.
Right, it's an actual surgery.
Yeah, it involves excision. So the physical cutting and suturing of excess tissue to reduce its size, it's subtractive.
Subtractive, right.
But labial filler is non-surgical and additive. It's an injection specifically designed to restore that lost volume to the labia majora.
So you're adding something back in.
Exactly. You cannot use a volumizing gel to tighten drastically lax skin or, to mimic the results of a surgical excision.
Which means the initial clinical assessment has to be everything.
Oh, it dictates the entire treatment plan.
A practitioner can't just eyeball the area and start injecting, right?
Yeah.
They have to map out a highly complex anatomical region.
Yeah, because we're talking about navigating around the branches of the pudendal arteries and a really dense network of nerve endings.
Which sounds terrifying if you get it wrong.
Well, injecting blindly into this space could compromise major blood vessels or cause severe nerve trauma.
So how do they safely assess it then?
Well, to navigate that complexity, clinicians rely on these highly standardized empirical measurement scales before a needle ever even touches the skin.
Like a grading system.
Right, completely removes the guesswork. For instance, there's the Motakef classification. It's used to indirectly assess the anatomical proportion.
The Motakef classification.
Yeah. It gives the doctor a structural grading system to measure the protrusion of the labia minora relative to the labia majora. So it objectively determines how much volume is actually required to restore that protective anatomical balance.
But the physical measurement is really only half the picture in the literature.
True.
The sources dive really heavily into the FSFI, which is the Female Sexual Function Index.
That one is crucial.
Yeah, because it evaluates 6 different domains, right?
Yeah.
It looks at desire, arousal, lubrication, orgasm, satisfaction, and pain. So it's measuring physiological responses and overall quality of life.
Right. And when you look at the FSFI in conjunction with the Moteca classification, the underlying logic of the assessment just becomes perfectly clear.
Also.
Well, the structural deficit that you measure with the Mertek scale directly causes the functional deficits measured by the FSFI. Yeah, without the structural cushion, physical friction increases, and that directly causes pain during intimacy.
Which would obviously diminish arousal and satisfaction.
Inherently, yes. It creates this negative physiological feedback loop.
And to capture the psychological toll of that loop, the literature also introduces the PSS, the Perceived Stress Scale, alongside the GAIS.
Right, the Global Aesthetic Improvement Scale.
Exactly. So the PSS measures the patient's baseline anxiety and quality of life, while the GAS measures their visual satisfaction after the procedure.
The interplay between all these scales is just fascinating.
It really is.
There's a randomized controlled study featured in our sources where researchers evaluated 76 women, all between 40 and 65 years old, and all diagnosed with labia majora hypertrophy.
So they all had that volume loss.
Yes, and at the 6-month post-treatment mark, the patients who received the hyaluronic acid filler showed massive improvements across the board.
They saw actual measurable physiological changes. Like the FSFI scores jumped up, indicating increased natural lubrication and significantly decreased pain.
Right. And because the anatomical barrier was restored, that physical friction just disappeared.
Wow.
Consequently, their perceived stress scale scores plummeted, and their aesthetic satisfaction on the GAIS was exceptionally high.
So restoring the physical architecture literally naturally resolved the psychological and sexual dysfunction.
Exactly.
That's incredible. So once that baseline is established and the volume deficit is actually quantified, we have to look at the physics of the procedure itself.
The mechanics of it, yeah.
Like, how does a doctor safely navigate this highly vascular, deeply innervated tissue? The area is packed with nerve endings, so safety obviously has to start with pain management.
Oh, absolutely. The protocol demands a really multi-layered numbing process. You have to remember, mucosal and vulvar tissues have a different barrier function than, say, the skin on your arm.
Right, they absorb things differently.
Much more rapidly. So first, a high-strength topical anesthetic cream is applied just to desensitize the surface.
Okay, so that gets the top layer.
Right. And once the surface is numb, the practitioner administers an injectable local anesthetic, typically lidocaine, to block the deeper nerve pathways.
So they're numb all the way through.
Exactly. And modern premium hyaluronic acid fillers actually come formulated with lidocaine baked right into the gel itself.
Oh, that's smart.
Yeah, it provides a continuous numbing effect as the product is introduced into the tissue.
See, I always visualize filler procedures involving like a sharp needle just going straight into the tissue. But the literature heavily emphasizes the use of a blunt-tipped microcannula for this specific area.
Right, and there's a very good reason for that. A sharp needle easily pierces whatever is in its path.
Right, which would include veins and arteries.
Exactly, which drastically increases the risk of severe bruising or, worse, vascular emergencies. A blunt microcannula, however, features this rounded tip.
So it's not sharp at all.
No. Once a tiny entry point is made, the cannula is slid into the subcutaneous tissue plane. And because it's blunt, it gently pushes blood vessels and nerves aside rather than slicing right through them.
Wow, so it just glides past the important stuff.
Exactly. This allows the practitioner to lay down the filler in a smooth fanning technique across the entire labia majora with minimal trauma.
And the filler itself is where the science gets incredibly specific. I mean, we're talking about hyaluronic acid or HA, but the chemical structure used here is really unique, right?
Very unique.
Because natural HA in the human body breaks down via enzymes in a matter of hours.
Right, it doesn't last at all naturally.
So to make it last, scientists chemically cross-link the HA strands in a lab.
Wow.
And they often use a binding agent that basically turns the liquid HA into a three-dimensional cohesive gel matrix.
And the density of that matrix is crucial. The sources highlight that they use a highly specific, robust particle size for labial augmentation.
Because it has to hold up under pressure.
Exactly. I mean, if the HA particles are too small and thin, the product will just migrate under the sheer physical pressure of the area.
Right, from sitting or walking.
But if the particles are too large and rigid, the tissue will feel lumpy and completely unnatural.
Which nobody wants.
Right. They require a specific cohesive density that provides structural weight-bearing support while remaining pliable enough to perfectly mimic the elasticity of natural mucosal tissue.
The way this HA matrix settles is, honestly, arguably the most important part of the entire process.
Oh, without a doubt.
I like to think of the cross-linked hyaluronic acid like a completely dry, dense sponge placed into a highly humid room.
That's a great analogy.
Right, because when the doctor first injects it, you see the immediate structure. The contour and the bulk are there on day one. But that gel isn't just sitting inert in the tissue.
Far from it. Hyaluronic acid is hydrophilic, meaning it actively attracts water.
So it's pulling moisture in.
Exactly. Over the subsequent 2 to 4 weeks, that HA matrix acts exactly like your sponge. It chemically bonds with ambient water molecules in the surrounding tissue.
Oh, wow.
It pulls moisture into itself, plumping up and fully integrating into the extracellular matrix. It essentially becomes a permanent architectural fixture of the tissue for the duration of its lifespan.
It even signals the local fibroblasts to start producing native collagen around the gel.
It does. It's amazing.
But for you listening, understanding this 2 to 4 week chemical bonding process is vital because it explains the extreme strictness of the aftercare guidelines.
Yes, you have to protect that integration process.
Right. You can't just get this procedure and go on a 10-mile bike ride the next morning.
No, absolutely not. The final aesthetic and functional outcome is entirely dependent on how the patient protects that integrating sponge.
So what's the immediate aftercare look like?
Well, the initial inflammatory response to the cannula requires immediate management with cool compresses. Swelling is just the body's natural reaction to microtrauma, but excessive swelling can actually distort how the filler settles.
I'd imagine after a couple of days of this bonding process,
Mm-hmm.
you'd be fine to resume normal intimacy. But the sources are incredibly strict about absolutely no sexual activity for a full 7 days.
And that's non-negotiable, because in those first 7 days, the gel has not anchored itself into the tissue matrix yet.
So it's just floating there.
It's still highly vulnerable to shear stress. The physical friction and intense pressure of sexual activity can physically dislodge the HA bolus.
Oh, yikes.
Yeah, it pushes the gel into areas where it simply doesn't belong. And that results in permanent asymmetry, or these unwanted hard bulges that require medical correction.
Which also perfectly explains the rule against intense heat.
Right. No saunas, no hot tubs, no intense hot yoga.
Because heat causes vasodilation,
Right.
the widening of blood vessels.
Exactly. It floods the area with blood and fluid, which completely overwhelms that HA sponge and severely exacerbates swelling during that really critical early integration phase.
But sticking to those guidelines yields impressive longevity.
Very impressive.
Because the labia majora experiences far less dynamic muscle contraction compared to, say, the lips on a face, the mechanical breakdown of the filler is actually slower.
Much slower, yeah.
Once safely integrated, these cross-linked HA fillers maintain their structure and hydration for 12 to 18 months before the body's natural hyaluronidase enzymes finally safely metabolize the gel.
That 12 to 18-month lifespan is fantastic, assuming the settling process goes perfectly.
Right, assuming no complications.
But we really need to extract the vital safety data from these clinical studies regarding complications.
Hmm.
With any medical procedure, you have to know how to distinguish between expected, normal healing, and an absolute red flag.
So what is expected normal healing?
Setting realistic expectations is paramount. During the first week, patients will experience localized swelling, mild to moderate bruising, and tenderness.
Which makes sense.
Right. That is simply the immune system responding to the introduction of a foreign substance, and of course, the mechanical displacement of tissue by the cannula.
The ultimate danger in the dermal filler world, however, is a vascular occlusion.
Yes, that's the absolute worst case scenario.
For you listening, this occurs when the gel accidentally enters a blood vessel, forming an internal blockage. Or when so much gel is placed around a vessel that the external pressure literally pinches the artery shut.
And when an artery is blocked, the downstream tissue is starved of oxygen and nutrients.
It just cuts off the supply.
Completely. If blood flow is not rapidly restored, that tissue undergoes necrosis.
It dies.
It dies. This requires immediate emergency medical intervention.
The sources outline very specific clinical warning signs for a vascular occlusion that you really need to be aware of.
Yes, patients need to know what to look for.
The first is blanching. This is a sudden, stark whitening of the skin because the oxygenated blood has literally been blocked from reaching the surface.
Right, the color just drains out.
And the second sign is livido reticularis.
Livido reticularis presents as a sort of net-like, purplish or mottled discoloration of the skin.
It looks almost like a web.
Exactly. Anatomically, this happens when deoxygenated blood pools in the venules because the normal circulatory flow has just been disrupted.
You also want to look for delayed capillary refill.
That's a classic test.
Right. If you press gently on healthy mucosal tissue, it turns white momentarily under the pressure, but the pink color should return in under 2 seconds as the capillaries reperfuse.
Yeah, it should bounce back quickly.
If you press the skin and it takes more than 3 seconds for the color to return, the arterial flow is severely impaired.
Add to that severe, excruciating pain that is entirely out of proportion to the procedure itself.
A pain that just won't quit.
Right. Ischemic tissue that is dying from lack of oxygen sends massive distress signals through the nervous system. If the pain intensifies rather than subsides after the numbing wears off, the practitioner must be contacted immediately.
Absolutely immediately. But assuming the vascular pathways are clear, the literature also discusses complications regarding the texture of the filler as it settles.
Yes, textural issues can happen.
And wait, hold on. I was reading through the anatomical vector study in our sources, and it notes that if a patient developed cold nodules, like little localized lumps of product, the practitioner resolved them using vigorous massage.
Yes, they did.
That contradicts literally every single rule about facial fillers. If I vigorously massage a fresh lip filler on my face, it migrates everywhere and ruins the shape.
It sounds completely counterintuitive based on facial aesthetics, I know, but it actually highlights a profound anatomical difference between the two regions.
The anatomy changes the rules.
Completely. The lips on a face possess a very delicate, thin, submucosal layer. The labia majora, however, features a really thick, deep, robust fat pad.
So the tissue architecture can just handle a different mechanical approach.
Exactly that. When a provider encounters a deep, concentrated accumulation of cross-linked gel in the labia, a nodule that basically failed to spread out smoothly during the injection, they can apply firm, targeted, vigorous pressure.
Because it won't just spread into the wrong area.
Right, because the gel is locked within that deep fat pad. So the practitioner physically kneads the cohesive matrix, forcing it to fan out into the surrounding adipose tissue before the chemical bonding process fully sets in.
The massive caveat for you listening, though, is that this must be provider-directed.
Oh, absolutely.
If you feel a lump during the settling phase, do not attempt to vigorously knead it out yourself in your bathroom.
Please don't do that.
You lack the anatomical knowledge of where to push the product. Go back to your clinician and let them evaluate the tissue.
Skin integrity during this recovery month is another factor patients just often overlook.
Like keeping the area clean.
Clean and undamaged. The same study detailed a patient who actually developed a localized bacterial infection, a biofilm, 14 days post-procedure.
Oh, wow. 14 days later.
Yeah. And the root cause was a routine waxing treatment.
Because waxing literally rips the hair from the follicle, which creates micro tears in the stratum corneum, the outermost layer of the skin.
Precisely. And when you have a foreign implant like an HA gel sitting just below the surface, breaching the skin barrier is incredibly dangerous.
It's basically an open door for bacteria.
Right. Those micro tears allowed natural surface flora to travel down the damaged hair follicle and directly colonize the filler bolus.
That sounds awful.
It's serious. While the biofilm was efficiently treated with oral antibiotics, it starkly illustrates why any form of hair removal, trauma waxing, shaving cuts, or laser burns must be strictly avoided while that HA matrix is still integrating.
So if the absolute worst case scenario unfolds, a vascular occlusion, a persistent biofilm, or granulomas that refuse to integrate, are patients just trapped with this gel for 18 months?
No, and this brings us to the profound safety net of hyaluronic acid fillers.
The reversal agent.
Exactly. Unlike permanent interventions such as silicone or even fat grafting, HA filler is completely reversible.
It basically has a built-in biological undo button.
It really does. If a complication arises, the practitioner injects an enzyme called hyaluronidase directly into the area.
And what does that do?
This enzyme specifically targets and rapidly cleaves the chemical crosslinks holding that HA matrix together.
So it breaks down the sponge.
Right. Within 24 hours, the cohesive gel dissolves back into a liquid state, which the body's lymphatic system naturally just flushes away. It mitigates the long-term risk profile significantly.
That's incredibly reassuring. Well, we've covered incredible ground today, unpacking the mechanics of labial filler.
We really have.
We've seen how a taboo topic is actually governed by rigorous clinical science. It requires practitioners who deeply understand vulvar anatomy, specifically, the pudendal nerve and vascular networks.
It's highly specialized.
Yeah. We explored how structured assessment scales like the Mutakif and FSFI quantify both physical deficits and functional distress.
Because form and function go hand in hand here.
Exactly. And most importantly, we broke down the chemical reality of how that hyaluronic acid matrix bonds with tissue over 2 to 4 weeks.
Which necessitates those incredibly strict aftercare rules regarding friction, heat, and skin integrity to ensure a safe, functional result. The overarching lesson from the literature is that precision and patience are really what yield the 95% satisfaction rates we see.
The protocols work if you follow them.
Exactly. Restoring structural anatomy intrinsically restores physiological function and psychological comfort. The clinical frameworks are there to ensure it's done safely.
Right. But I want to leave you with a final provocative thought regarding the long-term physiology of this procedure.
Okay, let's hear it.
We established earlier that the hyaluronic acid matrix doesn't just sit there, okay? It actively signals local fibroblasts to stimulate native collagen production over its 18-month lifespan.
Right, it biostimulates the tissue.
So what are the implications for the cellular aging of our most intimate anatomy after a decade of repeated overlapping treatments?
Oh, that's an interesting question.
Like, are we just temporarily replacing lost volume for a year at a time? Or, by constantly manipulating the tissue to hydrate and produce new collagen, could we be fundamentally rewiring the biological clock of these tissues?
It's definitely something the long-term data will have to show us.
It's something to mull over. Until next time, keep diving deep.